Start us off. Welcome to today's CCHI community conversation on simultaneous interpreting in healthcare settings. Joining us today is Laura Holcombe, who began her interpreting career in the halls of hospitals. A certified medical and healthcare interpreter, CMI and CHI Spanish, she Brazilian is one of her languages as well. Brazilian Portuguese, I believe, but she'll correct me. She holds a Master of Conference Interpreting from Glendon College in Toronto and is director of String and Can Multilingual Online, which provides interpreting and tech services for online events. In her master trainer role, Laura specializes in peer practice experiences. CoLab for conference interpreting professionals, Lab 7, a practice-based collaboration for medical students and healthcare interpreters, and the virtual healthcare interpreting practicum for the Glendon College Master of Interpreting program in Toronto. Also joining us today is Erin Teskey, who is an assistant manager of the Interpretation and Translation Department at Stanford Healthcare. In this role, she oversees all of Stanford's video medical interpreting operations, including remote simultaneous interpreting. Erin is a certified healthcare interpreter, Spanish, and an ATA certified Spanish to English translator with an MA in translation and interpretation, Spanish English, from the Middlebury Institute of International Studies at Monterey. Last but far from least, Dr. Michael H. White is a pediatric hematologist and oncologist at the Aflac Cancer and Blood Disorders Center at Emory University in Atlanta, Georgia. He earned his medical degree at the University of Texas Southwestern Medical School, completed his pediatrics residency at Vanderbilt University, and completed his pediatric hematology and oncology fellowship at Emory University. Dr. White is a clinical researcher and specializes in taking care of pediatric patients with bleeding and clotting disorders. I would also like to take a moment and thank today's ASL interpreter, Glashanda, who is sponsored by M&N Language Services. And so without further ado, I would like to hand this session off to Laura to get us started on what I know will be an amazing conversation. Thank you all for being here.
Thank you so much. That was a great introduction. Thank you for having me. I'll speak on behalf of everyone here with that enormous thank you. I'm so excited. And this is a little different than I work because really I'm just dying to hear the thoughts of the 90 people we have on this call. And then that's kind of my methodology. And then we work backward from that. But we'll do a mini version of that here in this room. So Erin and Michael, where I want to start is not at the beginning and not at the end, but kind of in the middle of things. I want to understand, because I think what I want to hear from each of you, I have some thoughts around simultaneous, and I think you both have the keys to the practical application of simultaneous healthcare, simultaneous interpreting in the healthcare setting. So I'm very curious. We'll start with you, Dr. Michael, or Dr. White. I know you're in the South, so I'm making a leap.
You can call me Michael also. That'd be great.
Okay. All right, Michael. So I just like to understand your experience with, and I think we also have to talk about consecutive, even to talk about simultaneous, but more generally, your experience working with healthcare interpreters, and if you have experience or comparisons you can make between when it happens simultaneously and when it happens consecutively. I'd like to hear your perspective on that.
Yeah, thank you. Thanks for having me. I'll try to make this answer shorter because I feel like just this answer could be the whole 30 minutes because that's a lot. But I also did want to just say, yes, I'm a physician, but I'm a dad, I'm a husband, I'm a dad, I have 3 kids, I'm a road biker. Those are the things I like to do because I first and foremost see myself, just as a regular old person from a small town in East Texas. But I think what I'll say is my third child is my son. He's 10 months old and he was born with some congenital anomalies. And so, that has been very difficult, but I think this just brings me to my point of, yes, I'm a physician and I see things from the lens of a provider, but I'm also the father of a patient. And so I realized that in both of these encounters, the way that we experience these things in the healthcare setting are almost in a lot of ways the most important driver of how we experience it and feel like we came away from the situation and how we accept the knowledge and how we use it. And so even though I'm a native English speaker, I just realized that the language and how this process goes is possibly the most important part of it all. So I just want to acknowledge that. So, I mean, my experience with simultaneous is that I didn't even know that it was a thing. You're going to see how honest I am. I didn't know it was a thing until a colleague of ours, Andrea, at our hospital I would work with her with certain patients and she would perform, simul mode. And, I finally had a minute to stop and talk to her afterwards and say, this is amazing. The process that the way that you're performing this is amazing. What is it called? How do we do this more often? Why have I not known about it? And why does everyone not do it? So I'll just leave it at that and say it's been just a couple of years ago, probably 7 years into my 10 years of being a physician is when I first experienced this and realized how awesome and important it is.
That's useful. We didn't get to talk about it earlier, but I share on the road bikes. So
Great.
Save a road for me and we'll go together.
I will.
And I'm curious just to confirm, when you were working with Andrea, I assume there was no equipment involved. She just started working in simultaneous whispering, right? Lowering her voice.
That is correct, because I know we'll probably talk about virtual platforms, and I have not been a part of simul mode on virtual platforms. And so these are all in-person experiences. Yes.
Okay. And I really appreciated the introduction. Of course, I'm glad we're recording this. See, everyone? Michael thinks that what we do is important.
It's so important.
Aaron, what I like about what I just heard, Michael, is I, in a way, ended up developing my own simultaneous practice as well before I even had a good notion of the huge distinctions and what other people in the field thought about those two different ways of working as just a way. It was like the way I, as a being, absorbed all the different pressures in a certain situation, in a certain room, including time pressures on both people, the environment itself, what kind of things were in the way, the type of discourse that was happening. And so I started to develop a bit of a simultaneous practice as well, in the same way that it sounds like Andrea, at a certain level, there's a certain comfort level with who you're working with. And it becomes even a lot more possible when you're working with the same people repeatedly, or even the same patient repeatedly. And I had one provider that I worked with, I remembered, who I started in the simultaneous mode. And she was just like, whoa, don't do that. Don't do that. I can't do that. And so it is good to point out that I think for some people, having two voices, even if you as an interpreter are kind of using your voice correctly in a thoughtful way to minimize that interference, that for some people that will just be, it won't work for them. But by and large, I got a lot of positive feedback from people as well from that simultaneous. Now, fast forward, and I went and got a master's degree. And in that coursework, I learned no, consecutive is the preferred mode in healthcare. And so I thought, oh no, I was doing it wrong the whole time. and because simultaneous is too distracting to patients, this sort of thing. And so I took that as the word of God. And then I moved on, and I started rethinking things as one does, building on what people before me had passed to me. And I started thinking, and I wish I won't interrupt Glashanda to get her to participate in this conversation, but I thought, wait, our ASL brothers and sisters, they virtually always work in simultaneous. And there's no reason why in healthcare simultaneous can't work. The reason we haven't used it very often, I think, and I want to hear from Erin on this one, we haven't so far, is one, we think of simultaneous as being done with specific equipment and booths and this sort of thing. And you can't set up a booth with transmitters in every environment that a patient and provider are going to be in. It just wouldn't be reasonable or desirable. And then the second reason is because I don't know what came first, chicken or the egg, but we weren't training healthcare interpreters to work in this mode. So at that point, it does become a less desirable mode. And so what I have gone back and thinking, like mainly inspired by ASL interpreters, is like, okay, there's no reason we can't use simultaneous in the healthcare. There's no innate reason. It's just getting all the pieces in place to make it more user-friendly. So Erin, what I want to hear from you is a little bit about, where your thoughts about simultaneous or first experiences with simultaneous in healthcare, where that started for you, and how you think about the impracticalities of simultaneous in the healthcare setting and how those can be managed.
Great, thank you so much for those questions, and it's really wonderful to just even the start of this conversation. So I'm really excited about that. I have a feeling that 30 minutes is not going to be very much time for us. I started with simultaneous interpreting in the healthcare setting in kind of your typical almost conference interpreting group classes. So I came to this profession through training at MIS and with a master's in conference interpreting. So I started in the conference world and then added medical terminology on top of that. And so when I first did simultaneous, it was during my internship at Stanford Healthcare, and we have solid organ transplants and bone marrow transplants. And for those programs, there are usually teaching sessions that are group classes where many patients who are going to go through the transplant process are learning about transplant. And so we have portable equipment, and we would have our interpreters sort of switching into the assistant manager mode. We would sit at the back of the classroom with a mic, and our limited English proficient patients and family members would have the receivers and listen to us. And so that point about provider preference really rings true, because even in those classes where we were using the equipment properly, we would sometimes have the teachers of the class ask our interpreters to sit outside the room, because even the quiet whispering into a mic behind a notebook was too distracting for them while they were teaching the class. So I really think about simultaneous interpreting as another tool in an interpreter's toolkit. So sometimes there's settings in which it really is the best. In some settings, it might not be the best. And sometimes it comes down to patient or provider preference. I think a really important thing to talk about is the time aspect of simultaneous interpreting, because we know that consecutive interpreting doubles the time of an appointment. And in healthcare today, there is such a pressure to get people seen quickly and to get a lot of information across. And in more complex settings like bone marrow transplant, there's also often so much information that needs to be conveyed. Anything that can speed that up can be helpful. Now, as the assistant manager with oversight for video interpreting, I'm doing a lot of work with remote simultaneous interpreting, primarily actually with bone marrow transplant for those group classes that have now moved to Zoom. And it's been really interesting to see how those classes have adapted to the platform. In some ways, I guess if you think about the impracticalities of that, there's a question of health equity access to technology. And so
Right.
sometimes the patients that need the interpreting don't have a way of accessing it easily over Zoom. And so there's definitely still a lot of work to be done, but I think there's a lot of promise there. And as our team has started doing more of this and interpreting more regularly, there's been more visibility around it. And we have a lot of we're blessed to have a lot of staff members that have training in simultaneous
That was
already.
going to be my next question.
And we have a lot of people who are pursuing training now that they see how much is being done with simultaneous interpreting. So it's really kind of wonderful to see how it's inspiring our already very, very skilled and qualified team to continue growing their skills.
Okay, this makes me think of two things. One, so I've done maybe 4 or 5 sessions of this where I am lucky enough to work with 150 medical students in a collaborative experience with healthcare interpreters in which each are learning from each other. And as part of that training, the third day, the first 2 days were basically it's an online sim lab, but with healthcare interpreters involved, right? So they're simulating different case studies, both and the medical students are consolidating their interviewing skills and thinking about and experiencing what it might be like to work via an interpreter. And these are very prepared, insightful students that we end up working with. And inevitably, the first observation that they have is like, whoa, that took a lot longer than I expected it would take. And I even heard a couple of them say, so you have to be careful about what you choose to ask and what you don't. And that got me thinking like, oh my gosh, yeah, it'd be nice to think that like, providers can just double their time and we're not making any sacrifices, but that's not in reality how it's going to play out. Like there's still so many people to be seen. And so what ends up happening is providers have to be extra efficient in their line of questioning. I'm curious, Michael, you can tell me how it plays out for you or what sort of strategies you use. And it got me thinking that it was totally to the contrary of what I had thought previously, which is, consecutive is the most accurate. It's the way that you work so that you're not confusing anyone. And then I realized actually there's so much room for a quality improvement because we have already language marginalized patients. Now they might have had to wait for an interpreter beyond other English speakers. Now, who loves being at the hospital? Now their appointment is going to take twice as long as anyone else's appointment. Though a provider can now communicate well with the patient, hopefully, they will still have the time pressure on them, which might lead to other, scrunching in of things. So I'm curious, Michael, in your experiences with interpreters, what do you do with that conundrum of the extra length? Or do you always have Andrea, so this isn't a thing anymore?
It's both. I never know who I'm going to work with. So there are several comments I'll make about that. One is my favorite situation is working with teenagers and young adults where I am speaking to them and you as the interpreter are performing simultaneous mode to the parent or family member.
A great application of simultaneous.
That is the most fun thing of all because it's so empowering. We already do a bad job as physicians. I don't usually speak on behalf of all of us, but it is commonly known that we don't do a good job of speaking to the patient, whether it's a 7-year-old or a 17-year-old. And it's really sad to see, but this is so empowering for me to speak to that 12-year-old and say, this is what we're talking about. This is what I'm doing. This is what we're going to do. And this can be simultaneously being interpreted. The time saver is amazing because if we are consecutive, then either I go late and it affects everyone else, or I have less time and that family gets less education and information, and that's really bad and inappropriate. But I'll also say I'm not a billing expert, but I want to throw out a comment that I don't know if it's been brought up, is like our billing has actually switched in the past year and a half or so to not just complexity-based billing, but actually to time-based billing. And so no one has taught me on this. So I'm more throwing this out to the universe. But when I spend more time, whether that even if it's because of a language a barrier and situation, then I'm billing for time. Now I'm in an academic group, so the money doesn't like go to me per se. But I just want to throw that out there, that money from the family or the insurance company covering that is at play there.
Which then just adds to this idea that it's an inordinate burden, I suppose. And
Yes.
I didn't know that any billing system ever worked on complexity. So I'll have to rethink my rates structure and start billing for complexity and time, all of it together.
It's complicated,
Aaron.
but yes.
Yeah.
Well, that's
Aaron, go
actually
ahead.
something that I wanted to mention. We have not done anything about this. This is all just, blue sky brainstorming, but I have had some conversations with some nursing managers in some of our units about incorporating language into the acuity score for patients, so that patients that do need interpreting are sort of coded as higher acuity and can get more resources as a result, or that there could be more wiggle room for timing. I am not a
That's
billing expert. I don't know how it works, but just that idea of recognizing that complexity. I think that the idea of the simultaneous interpreting for parents of adolescents is also, quite frankly, one of my favorite applications of simultaneous interpreting. And it's something that I've done a lot in our pediatric emergency room. And it really, you can see how it empowers parents to understand what's going on in a way that sometimes they don't get that access because it's so easy to talk to the teenager. And as a new parent myself, I would hate to not know what's happening to my child. So the idea that an interpreter can facilitate that understanding, but also respect the relationship between the patient and the provider is really wonderful. I know that I guess that's on the pediatric side. I mostly work on the adult side. And so I kind of want to loop back to the idea of consecutive versus simul in a regular, so to speak, patient-provider encounter. Because one of the things that I have found with my own interpreting is that I am not an expert in everything. And in medical interpreting, there's sometimes terms that come up or new medications that are being used that I need to ask for clarification about in order to really accurately interpret. And simultaneous doesn't always allow me to do that as easily, because I get in the rhythm of the simul interpreting. And as a trained conference interpreter, we are trained in coping strategies.
Like a train, just keep it moving.
You just keep it moving. And so if I miss a number, I go general. Whereas in the medical setting, I can't just round up your dose, right? And so having the
Michael's like, yes, please don't.
Yes, please don't. So I think that's, circling back to the idea of simul being a tool in your toolbox, but not the only one. I think that consecutive sometimes is important to use despite the time crunch, et cetera, because it does allow for higher accuracy in many cases. So just wanted to throw that out there too. I know that those were a few different random thoughts.
Do you mind if I ask both of you, because I'm also wondering on behalf of the room, but how often do you ask the speaker, provider, whatever you want to call them, what method they would prefer? I mean, is that commonly done?
Great question.
Great
Aaron,
question. I would say I don't usually ask.
Okay.
Part of what I was trained on with the internship that I did and medical ethics conferences, et cetera, is encounter management. And so as a trained interpreter, I'm sort of reading the room and trying to figure out what would work best. So I don't ask the attending in the PZD if they want me to do simul for the parent or not. I just scoot into the corner and sit behind them and start whispering in their ear.
What a novel idea, though.
Yeah,
How about we just
it is a novel
ask?
idea.
Yeah, I love that. How about we just ask also with knowing that there'll be providers that we work with or patients that we work with who will say, I don't know, you tell me, like you're the person who knows. So, and being equipped for all those situations. I think the question really points to, and this is, I think, where you were headed, Aaron, is often other reasons that people wouldn't ask is because so many healthcare interpreters don't haven't had access to training in simultaneous technique. And so
Yeah, I didn't.
simultaneous, feels so overwhelming to many healthcare interpreters. And that was something that I gleaned finally. I can't believe I didn't see it coming before, but in this last training with the online simulation lab with the medical students, I thought healthcare interpreters would by and large be like thoroughly excited to get in a simultaneous sandbox. And that was by and large how it played out. But there were a couple of voices who felt so overwhelmed by the idea and like they weren't going to be able to learn simultaneous, and therefore simultaneous interpreters were going to replace them. I could tell some of that idea like, oh no, if I don't learn how this new skill, I might be replaced. And so I think as I think here in the room, there's a consensus that there's actually a lot of benefits for simultaneous in the healthcare setting. And I think I just need to be more cognizant especially when I have a training hat on, that not all interpreters are super excited to stare down this really intimidating skill. And to add on to that training bit, it reminds me, Aaron, and Michael, this is for your benefit too, that I need to find a better way. And this is where I'm a little bit removed from the practice. I live in Guatemala and there's no healthcare interpreting field. If there were one, it would need to be between indigenous languages and Spanish. That's what there should be, but there's not, because there's not legislation and there's no, there's no mandate legislation, money, etc. But effective ways of helping interpreters get comfortable with that muddiness between simultaneous, but in a situation where you can intervene as yourself and clarify a number or clarify a term and have the doctor explain it and then simultaneously interpret that explanation. So often I would think, and I'm curious what you think, Aaron, because you might have actual more practice. I'm curious what everyone else in the room thinks about this. But if I were theorizing, I think what I might end up doing is using what we think of as a conference interpreting technique to finish the interpretation. And then the first moment where I can identify myself as an interpreter and get in there with Michael and say, did you say this or this? The interpreter, as the interpreter, was it this medicine or this medicine? And then he says it, and then I re-clarify. So it's like bringing together that accuracy and the ability to mediate and problem solve is what I like to call it, because I work with a lot of people from Canada who have a different sort of code of ethics. But the ability to problem solve that we train to so much on the consecutive side to make sure that we're being as accurate with this tender information as we can. And how do we merge that with this this other technique that has an immense possibility of just creating a better experience for everyone involved. So Aaron and Michael, if you have anything to add on, but I thought Aaron could give us a practical example of how you might do that, or you've seen other people do it.
Yeah, I have so many thoughts. I think, definitely the 30 minutes is coming short. And I just want to say too, I love the idea of problem solving. I feel like it's such a good term to describe what we need to do. I kind of want to take a step back and say two things. First, the fact that an interpreter doesn't feel comfortable doing simul or hasn't had the training in simul doesn't make them not an excellent healthcare interpreter, right? So we have a wonderful, highly trained team some of whom have training in simultaneous interpreting and some of whom don't,
Mhm.
and some of whom might not have training but do have experience in
Mhm.
simul and have
Mhm.
excellent skills as a result too. I guess now when I put my assistant manager hat on, I never want any individual interpreter to be placed in a situation that makes them feel uncomfortable where they don't have backup from somebody. And so what we run into sometimes is that if there are providers, generally speaking, who have the expectation that an interpreter is going to use the simul mode, and they happen to get an interpreter who isn't trained or isn't comfortable with simul, we have had some situations where our team
Mhm.
feels uncomfortable
Mm.
and doesn't know how they can advocate for themselves. I think we also really need to recognize that there's a power dynamic in hospitals. And, it's wonderful to have encounters like these where we have interpreters kind of interacting with physicians as peers, but in the hospital setting, sometimes that is not possible, and interpreters are not fully recognized as colleagues. And so I just kind of want to hold all of those things as true in this conversation because Simul is a very good tool, but there are caveats still to it. And I would love to see a future where we do have robust training programs where interpreters can
Mhm.
develop those skills and we have more awareness on the provider side of what those different modalities mean, when they're appropriate, when they're not, what are the pitfalls. And I guess circling back to the clarification question,
Mhm.
if there's a power dynamic there where a provider is, and it's happened, they're out there,
Yeah.
has said, I need to see this patient. You need to do your job to interpret, just interpret what I say, doesn't stop for consecutive interpreting and just kind of goes along. And you have
Mhm.
an interpreter who isn't ready to do simul
Mhm.
and doesn't feel comfortable asking for that clarification. That's where things could get really tricky.
Yeah.
So
And first of all, good for that interpreter who says, I'm not comfortable with doing that, right?
Yeah.
yeah,
That's professionalism.
definitely.
They've granted us 5 more minutes. So we can't leave this conversation without looking like a little bit at technology. And I wanted to hear from you, Michael. I'm betting that your hospital system has like a multi-tiered approach, probably something like Stanford has as well, where you have on-site interpreters, but then you might also have a company that provides video services and telephonic services. And I'm wondering your feelings about that, and particularly in regards to simul. Because on-site interpreters, some hospital systems might have portable equipment, which makes our job marginally easier. Many do not, but we now have technology where we can have language channels for interpreters working remotely. But again, there's a training piece there that's probably missing in the healthcare setting. But I'm wondering, where would you, everywhere is the answer, where and how would you like to see simultaneous applied? Like if your video remote, if you could hand an iPad to the patient that's set to the Mandarin, set to Chinese,
Yeah.
and you're set to the English channel, and you can do it like that in simultaneous, would that be great, or can you see drawbacks?
That would be great. That I am aware of, we do not have the equipment to do that. And that also tells you that if we do have the equipment, then I don't know about it. And so, yeah, sorry, that very much shortens my answer because I do not think that we have the equipment to do that. We have, like, for instance, a single iPad on a stick, as they call it, and it's connected by wires that are zip tied down to the speaker and so forth. And so I don't really have the ability to do that. And also in the bowels of our building, we have poor internet service sometimes, which is very strange.
And very
that,
real. Mm-hmm.
and very real. And that highlights a lot of issues. But I really wish that we had those capabilities, and of course, I'm going to take all this and go ask about it and find out more and push for it.
So
But
cool.
yeah, it would be so beneficial to have that ability.
Okay. Yeah. I mean, the ability does exist, but we really are Aaron might tell me differently, but we really are at the forefront, and we're just missing those extra, like, okay, we need to actually get good at, like, where's a repeater so that we can boost the internet signal down here, or where can we wire in? And then we need one more, we need a device for each person so they can listen to their own channels. Aaron, you've already done some of this though. Come on,
Yes. So
tell us
what
how
I
it
want to
goes.
say is that so working for a large academic hospital system, there's a lot of things that are not within our control in terms of platforms, for example. So we use a video platform for telemedicine visits that does not support simultaneous interpreting.
Okay.
And so, and that is not a decision that came from our department. It's a decision that came from on high, and it is what is being used. And so we have been able to implement RSI over Zoom in select settings, working very closely with providers, but definitely
Where
not
you have more of a choice of the platform.
exactly. Yeah,
Okay.
but not as a standard.
Okay. Yeah. Okay. And I assume security is part of, or just
Yes, although
economics.
yes, maybe all of the above. I
Okay.
know that there is, HIPAA compliant Zoom. There's I think there's just big questions about integration with the electronic medical record system and the patient portal, and whether that gets localized, and just all of these things that we can collaborate on, but don't come from us. And so there's a lot of advocacy work that's done, not just in an encounter level, but also sort of at an institutional level, of saying, for example, you're giving instructions to patients via the app. The app is only available in English. What happens if a patient needs instructions in another language? So this is going to really bring us into the weeds, but these are all big questions
I think I can bring it back in from those two answers. And one is, we're doing it, so we're wrapping it up. Okay. The way I can bring that back in is, it sounds like there's plenty of realistic ways to implement it. It's more thinking about training and mindset and access to resources for interpreters, and then just a couple of people thinking a little bit ahead of the frontier in hospital systems to say, like, let's buy some portable equipment, right? And use it in different situations to make simultaneous better. We can do simultaneous anytime, whispered, assuming we feel comfortable and we've had support to do it well. But that extra option of portable equipment, and then teaching interpreters to use portable equipment, which is another gap, which is very intimidating, would mean that on-site simultaneous could become a lot more viable right now, as soon as we as collectively as a field say, let's head in that direction. There's enough benefits, and we just need to put the couple of pieces in place to support it. Simultaneous at a distance, RSI, which is originally my inspiration for thinking that we can't put in a booth, but we have platforms, and you can put that in hospitals. I initially thought that would be our way in, but I think it might end up being the reverse. That simultaneous happens on site in an on-site capacity. And then from there, more and more platforms end up integrating channel technology into their platforms, because, as Aaron said, you can't just go out and say, this is the platform I want, so everyone move here so that we have language channels. That might be the way. I don't know. Any final comments from I'm tempted to say the peanut gallery, just because, but you guys aren't the peanut gallery. You're the esteemed guest. So, Michael, any final thoughts? Or it even doesn't even have to be on simultaneous. It's just such a pleasure to have a provider in the room, and we as interpreters so often wonder about provider. We just, it's, the whole thing is devoid of provider feedback.
Yeah, I can imagine that. And I just want to say, yeah, you're so respected as your role. And so even before preparing to join the conversation, I think my mind widely opened to how much work and how much skill goes into this. And I of course apologize for people who are jerks, basically. But yeah, the power dynamic is unfortunately real, which should not exist. But I think I definitely encourage you to ask me and people like me, like, how can we interact best? How can we make this experience best for the patient and their family? And so I definitely encourage you to do that, because I think that's what was done for me. And I have learned so much, and my patients and their families benefit from it so much. And I agree that there are times and situations where different methods seem appropriate. And I think that that's a cool thing and very dynamic.
And I guess my closing thought is that any progress on this is going to be done in collaboration. It's not going to be done by anybody in isolation. And so having
Yes.
these kinds of conversations, identifying wonderful providers with whom we can work to implement this, it's really how we're going to be able to make these changes. And so I think that's something that I am excited to see continue.
Agree.
And it's what I love about the healthcare setting, man. I love healthcare interpreting because everyone's there for the service, you know, everyone's there for, like, how can we support each other to hopefully support this person who's not well and needs some expertise and some care in all senses of the word. So, all right, someone cut us off.
Well, guys, I just want to say this has been phenomenal, and probably we could go on for another, good 20 minutes, but I am going to cut you off here. And just thank each one of you for being here again today. Our ASL interpreter, phenomenal work there. So thank you as well. Thank you to everybody else who's on from the Peanut Gallery, listening in to us, joining us for this live interactive engagement on such an interesting topic that I absolutely love and live for. So we just want to thank you all again from CCHI for being here. Spread the word. Share this once it's posted to our YouTube channel. We look forward, of course, to hosting another interesting topic. So do also look out for the next announcement for the next topic. And thank you, everybody, once again. It's just been a pleasure listening in on the three of you. So thank the three of you and our ASL interpreter. Bye for now.
Thank you all.